All right, everyone, it is 12 o'clock and we'll go ahead and get underway. My name is Dr. Jeremy Whitaker, and I'm a board member and president-elect of the Iowa Public Health Association. I'm grateful you've joined us today and hope that you will continue to meet us daily to support our public health colleagues as they present their work. As you know, we usually meet in person to share best practices and lessons learned. As this year's conference co-chair, I particularly miss seeing everyone in person. We were grateful for the opportunity to share important work to a broader audience. Right now we have about 40 people on the line, but over 100 have signed up, so hopefully a few more join us as we get going today. The Governor's Conference is put on every year by the Iowa Public Health Association and the Iowa Environmental Health Association. I encourage you to join your public health colleagues as a member of either association. Our mission is to unite and strengthen the voice for public health in Iowa, which is exactly what we are doing here today. I also want to thank the sponsors and exhibitors of the virtual Governor's Conference who stayed with us even though our physical conference was canceled. Their commitment to public health is vital, especially in these times. Sponsors of the virtual conference are Aetna, Mayor Group, Unity Point Health, and the University of Iowa College of Public Health. You will find a list of virtual exhibitors on the Governor's Conference website at iowapha.org. Before I introduce today's speaker, just a reminder that everyone is on mute, and to ward off any Zoom bombers, the chat function is set to only allow you to communicate directly with me. At the end of each presentation, there will be time for questions. Please use the chat or Q&A at the bottom of your screen to ask a question. I will then read your question to the presenters. Today, we were originally scheduled to have 3 presentations. However, Dr. Michelle Devlin had a family emergency at about 10 o'clock this morning and was not able to be with us. Neither of today's remaining sessions were pre-approved for CEUs. However, they will be included on your certificate of attendance in case you wish to seek credit on your own. Today's first presenters are Megan, Becca, and Alicia. I'll give them a moment to introduce themselves a little bit more later. They will be discussing the important partnership between local public health and emergency departments when it comes to people living with HIV. At this point, I'll hand it off to Megan.
Hi, everyone. Thanks for joining us. So I'm Megan Bernabe. I am a clinical pharmacist in infectious diseases and antimicrobial stewardship at Mercy Medical Center in Cedar Rapids. And we were also going to have Alicia Steins with us from Linn County Public Health, who's the HIV, HCV, STI outreach coordinator, but she may or may not be able to join us due to the COVID pandemic going on. And then Becca, I'll let you go ahead and introduce yourself.
Okay, good afternoon, everybody. My name is Rebecca McKay. I'm a PharmD MPH candidate at the University of Iowa. I'm here with Megan and Alicia to talk to you guys about our pilot program between Mercy Medical Center in Cedar Rapids, Linn County Public Health, and the Iowa Department of Public Health. Our presentation today is called Local Public Health and Emergency Departments Work Together to Make Progress in the HIV Battle. We are going to tell you more about our pilot project and hopefully get you engaged at the same time. We have a couple poll questions that will hopefully cooperate. So today's presentation is going to be laid out in the following 3 sections. I'll tell you a little, actually Megan will tell you a little bit about the background of our project. I'll go through the results and then we'll tell you about kind of lessons learned and what direction we see this heading in. So the purpose of our pilot project is to improve emergency department screening processes to ensure HIV positive patients are identified every time. In Iowa, we have a relatively low incidence of HIV, in the broader picture of our country. So sometimes these patients can be viewed kind of as like a needle in the haystack. And we think that if we really develop our ED screening processes to make sure that folks who should be getting HIV tests are getting HIV tests, And so we've developed a screening algorithm and we implemented it in the Mercy Medical Center Emergency Department over the last several months and are here to talk to you about our results. So our first poll question, which I'm going to open up, so hopefully you guys can see it. We want to know, for those working in a hospital setting, are you aware of a process in place in your emergency department for HIV testing? I'll give you a few moments to respond here. It looks like it's working, so that's fabulous. Okay, so I got about 12 votes and more are coming in, but it appears that most of you guys are not aware of a process in place in your emergency departments for HIV testing. So thank you for your participation, and we will kind of loop back around to this towards the end. I'm going to end this poll now. Oh, okay, and there's our results. So now I'm going to pass it over to Megan to talk to you guys about how this pilot project came about and the timeline of some of our major events.
Thanks, Becca. So starting off in January 2019, we had talked about this in our antimicrobial stewardship committee. We had noticed that we weren't really testing anyone in our emergency department for HIV. And so after that discussion, our infection prevention team, they recommended reaching out to Lynn County Public Health, specifically Heather Metter and Alicia. And so we decided to meet and discuss this collaboration. And then in February, after that initial meeting, we pulled together a bigger meeting of stakeholders at Mercy Medical Center, so included Lynn County Public Health, as well as our lab, social work, the ED nurse manager, ED medical director, and pharmacy, and came up with kind of a basic framework for how to do this. And everyone was on board and agreed it was a good project to pursue. And then in March, Lynn County Public Health reached out to Iowa Department of Public Health, and we drafted our workflow and algorithm in more detail that I'll show you here in a few slides. And so then on to April, we did get approval from IDPH for this pilot program for 3 months, starting July 1st, 2019. And then in May of 2019, we finalized that workflow and the algorithm, and Becca joined our team. She's completing her MPH practicum as part of this project. And then in July, when the program started, we met with our ED physicians, and thankfully they were supportive in going forward. And so we had some discussion about how we could make the HIV test easy to order, and we ended up adding it to an STI panel that we have within our electronic medical record. But the physicians at that time felt they did not want it pre-checked. They wanted to have that decision point of whether or not they wanted it ordered. So then moving on to August 2019, I went back to their provider meeting because we hadn't really had an increase in our testing from July 2019 compared to July 2018. And so we did get their approval to have this HIV test pre-checked on that STI panel. And also the mid-level providers were at this meeting, which was huge because as you'll see in some of the later data, they are the ones seeing a lot of these patients that present to the ED for STI screening. And so then into September, we did get approval to extend the pilot project for 3 months. So it went from July 1st, 2019 through December 31st, 2019. And then January of 2020 is when we completed the data collection and analysis, thanks to Becca. And so then on to our next slide. This is our finalized algorithm. So starting towards the top left, so it was mostly a provider-driven HIV test in high-risk patients, so STD suspected or known or an IV drug user. We also had the ED pharmacist review patients as able and recommend testing, and then we would send that test to our lab. Then the next decision point is if it's positive or not. And then a change for us was sending that test to State Hygienic Lab for the confirmatory test. And then we had some further decision points, whether the patient was still in the emergency department or not, to coordinate the follow-up, which was a huge part of getting the provider buy-in on this project, because that was their main concern, and why they weren't testing patients in the ED is because they felt they couldn't handle the coordination of care and the follow-up. So if they were still in the emergency department, we could, give them the result. The social worker could help with counseling and giving them resources, and then we would contact Linn County Public Health so that they could follow up on the confirmatory result. If they were no longer in the ED, if they were admitted or from a clinic, then our infection prevention team would follow up with them. If they were in the community, our ED pharmacist would notify them via phone of their result. And Alicia put together a great script to help the pharmacist with delivering this type of result. And then the ED pharmacist would contact Linn County Public Health so that they could follow up with the patient in the community.
Okay, thank you, Megan. So now I'm going to tell you a little bit about our methods and how we went about collecting our data for this pilot project and the results, what we found. So this was a retrospective chart review. We included all patients who presented to the Mercy Medical Center Emergency Department who received STI and or HIV screening. So we had 725 patients receive STI testing and 225 patients receive HIV testing. And there is a little note here that 57 HIV screening tests were done in the absence of an STI screening. These were mostly folks with occupational exposure, maybe a needle stick, or folks who were aware that they were high risk and were receiving testing periodically, but did not suspect that they needed STI testing at this time. We did exclude source testing for HIV exposure. So say a patient of a nurse who got a needle stick, etc. Those folks were excluded. And I think there might have only been one or two to begin with. So now I want to tell you a little bit about our patient demographics. Most of our patients were between the age of 15 and 44 years old. The green bars, which are pretty small, hopefully you can see them. So our HIV positive tests, one patient was between the age of 25 and 34, and two were between the ages of 35 and 44. Most of our patients were female. About a quarter of all patients screened, whether for STI or HIV, and also about a quarter of our HIV tests were females. Most of our patients were either white or African American, and most of our patients had public insurance. 17% also had private, and 13% were uninsured at the time that they presented to the ED. So we only had documented risk factors for 202 of our patients. So a minority of patients actually had documented risk factors in the provider note from that encounter, most of which were suspected STIs. So here is kind of the meat and potatoes of our pilot project, the results. So as you can see, our HIV screening rate, and this is for only patients who presented for STI testing, so 225 minus 57, we get 168. Of our total patients of 725, and here you can see we tested 23% of our patients for HIV as compared with 6.6% from our control period of 2018. Our incidence rate of HIV did increase. During our control period, we had 2 HIV positive patients, and in our pilot project period, we had 3 positive HIV patients. And as you can see, much more screening. So that is good. Now I want to talk to you guys a little bit about the provider type. As Megan mentioned earlier, mid-levels were a huge focus of ours. Nurse practitioners, PAs. As Megan mentioned, they're often seeing these patients in the EDs, and you can see here that they did conduct a majority of our tests, both for STIs and for HIV. And now we have a couple patient stories, and I will ask that our coordinators today would check and see if Alicia Steins has joined our chat. Otherwise, I will happily go through these with you.
It does not appear that she has.
Okay, no worries. Like Megan said, she's been very busy with Linn County Public Health mitigating the COVID cases up there. So I'm going to tell you guys about our 3 HIV positive patients from our pilot period. So client A presented to the ER with abdominal pain, sores on her legs, and fevers of unknown origin for 1 week. Patient is foreign born and migrated to the United States in 2014. The Mercy ER provider ordered a panel to screen for STIs. This panel did include HIV testing. The hospital lab utilizes the HIV Architect test to screen for HIV. The test result was positive and a blood sample was sent to the state hygienic lab. Mercy staff notified Linn County Public Health of the result, and they were able to fax the lab request form to SHL, or the state hygienic lab. Once the confirmatory test was resulted, Linn County Public Health was able to meet in person with the client and provide her the positive HIV result. She reported fevers that had been ongoing for almost a year. She did not know the date of previous HIV testing and reported it was not part of the testing required to enter the United States. She was also concerned for her spouse and children, and Linn County Public Health was able to assist her in enrolling with the Ryan White program for ongoing care and HIV testing for one of her children living in the household. So that's our first client. Client B presented to the Mercy ED with testicular itching for 1 week. He denied penile discharge, fever, chills, sore, or rash. He was identified as a male who had sex with other males. According to the EHR, he had had 3 emergency room visits in 2018 and 3 in 2019 for STI testing, and no HIV testing was performed at any of these visits. Thanks to the pilot program algorithm, the Mercy EAD provider ordered STI testing that did include HIV testing. The sample was confirmed with the state hygienic lab. However, the client had left the ER prior to receiving his preliminary results. The patient was a little bit tricky to find after they left the ED. They had an address in a different county, and Linn County Public Health was able to notify that county health department and to assist connecting this patient with follow-up care. After kind of a long series of trying to track down the client, they were successful, and Linn County Public Health was able to connect this client with Ryan White case management and assistance to medical care. Finally, client C, this patient presented to the ER requesting HIV testing due to the inability to gain weight. They had a history of multiple ER and urgent care visits with urogenital complaints over the last several years since 2016. However, they did not have HIV testing completed at any of these visits. Again, per the pilot program algorithm, The ED provider ordered an HIV test, and confirmatory testing was conducted at the state hygienic lab. Client C was notified of the preliminary HIV positive test result while in the ED, and they were connected with a social worker and Lynn County Public Health, and they were able to connect this patient with, again, Ryan White Case Management Service, and connected them to follow-up medical care. So now, after we presented you with all of this information, I'm going to pass it back over to Megan to tell you about some of the take-home messages and lessons we learned from this pilot project.
Hi, everyone. I think Alicia is on the phone, so I'm just going to give it a moment to see if she can speak.
Are you able to hear me?
Yes.
Thank you, Alicia.
Oh, there. Hi. Yes, I have been on. I just couldn't figure out how to get unmuted, so I do apologize about that. Thank you, Becca, for reading those patient stories for us. Some of the lessons we learned while implementing this pilot program with Mercy Medical Center was follow-up, making sure we were able to connect individuals who did result positive for HIV to Lynn County Public Health, made the emergency room providers more confident in follow-up. As Megan and Becca alluded to earlier in the presentation, the emergency room providers were hesitant to even complete any HIV testing due to the fact they were concerned as to how were they supposed to follow up and provide case management for those individuals. One other lesson we also learned was, as one of the slides showed, we did test less men and more women due to the STI panel was more for a gynecological exam for a female. So some of the providers would only test men for the gonorrhea and chlamydia by urine sample and not order the STD panel itself. So the need there for sex-specific STI and HIV emergency room testing panels to ensure equal screening through both genders. Mid-level providers were the ones who were more likely to see patients presenting to the emergency room for STI and HIV testing in the emergency room. So just providing them with some basic education would be more beneficial, since those are the main providers seeing those patients. And then also, some providers weren't aware of the HIV testing consent laws in Iowa. So some other lessons learned were in regards to providing some education to those providers. Another lesson that we did learn was also adding syphilis testing would be beneficial to these panels, because overall there was a lack of syphilis testing being performed in the emergency room. We felt as if maybe just tackling HIV and implementing that first, and then having the discussion at a later date with those providers to encourage syphilis testing as well. And our other lesson that we learned was HIV screening is not outside of the scope of practice for those emergency room providers. Recommendations for the future going forth is continuation. We would like to make the partnership with Mercy Medical Center, Iowa Department of Public Health, and Lynn County Public Health a permanent partnership to expand and then also expand to other hospitals within the area. How are we going to be able to do that? We need some sustainability. We need to work with the lab to ensure that we are able to bill clients' insurances to maintain the program itself. And then also expansion, implementing this process across Iowa emergency rooms to enable multiple entry points for HIV testing to identify those individuals who are positive, and then also get them into case management So one of our other poll questions, I know Becca was, if you could open that poll, is do you plan to implement your own process or partnership within your local agency to increase HIV testing through your emergency rooms?
And the question is going to read our initial poll question, but if you could just reply yes or no to the question on the screen, that would be great. So do you plan to implement your own process to increase HIV testing in your practice site? Alrighty, so I got a couple of votes here. I have 2 participants who say yes, they plan to implement their own process or partnership, and 5 participants who say no. And I suspect this is because it can be kind of intimidating, and a lot of work did go into establishing this partnership, you know, months and months of collaboration between Megan at Mercy Medical Center, Linn County Public Health, and Iowa Department of Public Health. So it is definitely a huge undertaking, but I think our results did show that it was a meaningful pursuit. So here's our contact information. We do have a couple of minutes for questions. So let's hear them.
Yes, that is my cue. I did have one submitted through the Q&A, and it asks, did you track how many tests were made due to ED pharmacist recommendation?
Hi, this is Megan. We did not, or we haven't at this point. That would have been a good piece of data to have. Our ED pharmacist should be documenting interventions via this function in our electronic health record. So that is something we could go back and look and see how many were documented, how many recommendations were documented for HIV testing. But there is always the chance that it wasn't documented, so it won't be an accurate number, but at least we could get an idea of that number.
All right, thank you. Are there any other questions in the Q&A? I had one, basically, were financial constraints an issue?
Hi, this is Alicia. Can you hear me?
Yes.
So this program was actually a grant-funded program for this pilot. So that's why we are looking at that sustainability piece and seeking approval from Iowa Department of Public Health to continue the partnership, either if that's going to be through grant funding and or working with the lab regarding billing insurance.
All right, and that actually dovetails to that. Another question, and basically, do you think the program's sustainable basically using insurance instead of grant funds?
Yes, if we could work out the piece with the lab that we are currently working with.
Okay, and again, it was a few slides back. What percentage were currently under private insurance? Was it about a third?
I think it was less than a third. Yeah, so 70% are public, and Iowa Medicaid would cover, to my very limited and tertiary understanding, I think Iowa Medicaid does cover confirmatory testing, but to, you know, verify that for yourself.
All right, are there any other questions for our panelists today? I'm giving everyone a second to type in case anything comes in. All right. right, well, seeing no other questions, I'd like to thank Megan, Becca, and at the end, Alicia, for joining us and presenting today.
Thank you.
All right.
Thank you.
Now, next up, we have Devin, Jacob, and Brianne, all from Des Moines University, who will discuss drug-related mortality in rural Iowa. And so I will give Brianne a moment to load the slides. And you can take it away, Brianne.
All right, now that I'm unmuted. So today we're presenting our investigation on the relationships between known risk factors and drug-related mortality in rural Iowa. As you mentioned, presenting today with me is Jacob Garner and Devin Neuwaller, myself, Brianne Cook. Also working on this project was our student lead, Nellie Gazarayan, and our faculty advisor, Dr. Gilletta. And otherwise, we're all students here at Des Moines University. Our project, we received funding, microgrant through the Rural Prep organization, which is focused on preparing future providers for practice in rural areas. Our learning objectives for our presentation and our project were to explore the impact of drug-related mortality on the geriatric and general population, to discuss the variables that may have affected rates of drug-related mortality in 5 counties in Iowa, and to compare and contrast variables that influence rates of drug mortality on the national and local levels. In our project, I wanted to identify, first off, that we encountered some obstacles in analyzing drug and alcohol-related mortality in the older adult community. Initially, we had hoped to use data from the Iowa Department of Public Health, but we were unable to obtain permission to use this data set. So instead, we changed our objective and used the CDC Wonder Multiple Causes of Death data, 1999 to 2018. We also experienced that the CDC Wonder data were suppressed to prevent patient identification because of a low number of drug and alcohol-related deaths in the older population, those aged 65 and older. And as a result, we were unable to perform further comparison in the older population. And because of these difficulty in obtaining data, we focused our research and made our objective on what factors contribute to drug and alcohol-related deaths on the national level based on previous research. In addition, we looked at how well these factors predict drug and alcohol-related deaths in rural Iowa counties as a whole. So looking into some of the background information ahead of our research, drug overdose is an issue that should not be considered limited to the urban setting. Although in previous studies that people living in rural areas have been identified at lower risk of opioid overdose overall, with lower rates observed in the north central states, including Iowa versus other regions. But this effect, there is a regional effect to consider. There have been increases in overdose in rural areas of Ohio, West Virginia, and Utah. Also effects seen across the Midwest. In addition to considering the high cost on health of individuals, it's important to consider the high economic cost of these overdoses. A single hospitalization for an overdose of amphetamines costed over $14,000 in 2016, according to this study. So there's a number of factors that can be considered on different levels that have been investigated in prior research. On the basis of individual counties, factors such as increased economic disadvantage, more service employment, and higher prescribing of opioids have contributed to a higher drug overdose mortality rate. Lower social capital has also been associated with higher overdose mortality rate. In this study, social capital is defined as networks, a sense of belonging, work with fellow citizens, and community trust that is found within a specific community. From a regional level, risk factors identified in a study that was performed in Wisconsin identified low income and education, including some college, as risk factors for drug overdose. At the national level, a study identified factors including unemployment, lower educational level, lack of health insurance, incarceration, and living in poverty, including high rental property rates. I did not include age-related or race-related factors, as there was high variability in the findings between the regional and national levels. Other potential risk factors that have been noted in prior literature, polysubstance abuse. In this study, there was an increase in amphetamine use noted in individuals with opioid use disorder. Other substance use was also identified in this article, but this was the only significant increase that was noted. Medical comorbidities may also increase the risk for drug overdose. In middle age and older adults, these individuals may be more likely than younger individuals to have an underlying health condition such as cardiovascular disease, which in this study was found to have a greater risk of adverse health outcomes in cocaine use. In another study, 71% of the rural counties surveyed did not have access to an opioid use provider, which could limit access to medications for treatment of opioid use disorder. In addition, depression is a common and under-recognized problem in the geriatric and general population. In this study, suicides rates were identified highest in the elderly aged 85 and older. There are a number of factors that may contribute to this in prescribing practices, as well as overlooked diagnoses. But in any case, there are a wide range of risk factors that may contribute to higher drug overdose mortality rates. There are effects on the regional level that are observed throughout the US. And with this concern, we wanted to answer the question of how these regional effects come into play in Iowa. So to discuss our research questions, I will now turn over the discussion to Jacob Garner.
Thanks, Bree. As Bree just addressed this first question, what factors contribute to drug and alcohol-related deaths based on previous literature, she noted that there are several things, including social capital, job types, and different things like that that could potentially be contributing to things in Iowa. They've been seen at the national level. Now we wanted to dig in here. So that's what that second question is. What were those factors? So on the next slide, we see we are describing our layout and development for our dependent and independent variables. Our dependent variable for our methods was the drug and alcohol related deaths in Iowa on the county level. We extracted the data for this from CDC Wonder and also from the Health Resources and Service Administration, as noted there. Below is some explanations of how we derive that data, but just in total, our dependent variable was the drug and alcohol related deaths. Go to the next slide. this is our independent variables, or predictor variables, is what we called them as well. We derive these from the Health Resources and Service Administration, as well as the U.S. Census Bureau and the Northeast Regional Center for Rural Development. Just a few notes: the Northeast Regional Center for Rural Development provided data regarding social capital, and in this instance, social capital was defined as religious establishments, membership associations, sporting establishments, and similar things. And then the rest of the data was derived from HRSA and the Census Bureau. Predictor variables are those factors we were talking about in the beginning, the things that have an increasing or decreasing effect on drug and alcohol-related death. The next slide, Bree. Here we list our predictor variables, and we've summed them up according to previous literature under specific headings. You can read through these here. I won't read them all off to you. Don't want to bore you with that. But the economic environment was a key overall heading that we looked at, as well as housing distress, labor market dependence, and social environment. On the next slide, we have a few more that we looked at. Here we have social capital, healthcare environment, and population characteristics. And again, just as I noted before, social capital is defined by those four different types of establishments in the area. You can go to the next slide. After we gathered the data, we went ahead and performed a statistical analysis. We generated descriptive statistics, which are means or frequencies within the state and county level. Within the state at the county level. And we broke those down again into metro and non-metro, and we'll discuss that later in the results. After we generated those, we performed a bivariate analysis to see the interaction between the independent variables and the dependent variable of drug and alcohol-related death. We also performed an analysis in between the independent variables to see how they affected each other. We don't have that presented here, that second part presented here, but we have it if anyone has further questions later on. We then attempted a multiple regression with these variables. However, because of multi-collinearity, or just a complex interaction between the independent variables, we were unable to get a good model with considering the independent variables by themselves. So we had to do a data reduction method called factor analysis, which condensed the variables into, we developed 5 factors that we then used for our multiple regression. Go to the next slide. So now into our results, this is our descriptive statistics, or means and frequencies. Just some things to know. On the metro and non-metro, where we've broken them down separately, these factors here of unemployment and poverty and disability, as we'll see later on, they fall into a category of factors together. And just of note, the non-metro tends to be higher than the metro on average in those areas. You can go to the next slide. Some more things to just look at. Of note, it shouldn't be too surprising to anyone, mining is not a really big thing in Iowa, but we have in non-metro areas or in rural areas, they also don't have any public sector. There's not a large reliance on public sector for job dependence. Go to the next slide. And then here we just have the social capital establishments again. Of note that they are higher on average in rural areas, which we'll see is a positive thing later on in our analysis. Go to the next slide. And then here, this discusses the healthcare environment of each county. And on average, you can note down there on the last heading, the percentage of county designated as a mental health care professional shortage area. This just means that they don't have enough like psychiatrists or other mental professionals at that area. And significantly, the non-metro areas, almost all, on average, they have a 97% shortage on a whole county level. That statistic. So just some interesting things that we noticed as we were reviewing the data. You can go to the next slide. And again, some population characteristics. There wasn't anything too unusual in this area. There's a significant, a small increase in population over 65 in the non-metro area over the metro. You can go to the next slide. So now here are our bivariate analysis results, just comparing the independent variables or the factors to our dependent variable of death and alcohol related, death due to drug and alcohol related. We have on the right, you can see a box indicating the statistical significance of the analysis. There were about 8 factors that were shown to be significant, including we have the unemployed and civil labor service, the civilian non-institutionalized, the proportion with disability, and we have the percent of females divorced as well there. Go to the next slide. And then on this one, we have a few more. As noted, the religious and membership establishments have a negative effect or a decreasing effect on the drug and alcohol related deaths. And the sports and establishments, physicians, and percent African American have an increasing effect. So as I noted, we did a factor analysis to break down, to group the variables into factors that we could use for multiple regression. Here they are. We grouped them and gave them a name just to kind of sum up what variables fell into each factor. The first one is significant reliance on government pay, and you can see that based on the disability rate, the percent of disability population, and also things like the household with supplemental security income. Factor 2 was a concentration of poverty based on unemployment and other factors similar to that. Factor 3 measures the presence of social capital, so based on religious and nonprofit and membership associations. And then the next slide, we have factors 4 and 5. Factor 4 has single female-headed family units and African American population. And factor 5, it shows a Hispanic and Native American population. So those are the 5 factors we grouped our variables into for a multiple regression. And that is what we performed here. And the factors that were shown to be statistically significant were 1, 2, 3, and 4, and they're listed there, their titles are listed there, so you can refer back to those. The factor 5 on Hispanic and Native American population was not found to be statistically significant, but we just are showing that here in this graph. Just of note that the factor 3 has a net decreasing effect, a negative slope or decreasing effect, and the others were all positive increasing effects. Now we'll move into our discussion section. Devin's gonna just talk a little bit more about our results and what they could potentially mean for further work in Iowa.
All right, thanks, Jacob. All right, so after all this data analysis, we want to see what did we find out. So we found that the drug-related mortality is relatively less prevalent among rural Iowa counties as compared to the national average. And we also saw that some of the established predictors of drug-related mortality at the national level are also operating at the local or regional level. Next slide. So we can see, even though people living in rural communities have been identified as at lower risk compared to those living in the urban settings, some rural areas have seen a noticeable increase in overdose deaths than others. So we saw that opioid drug mortality should not be dismissed as only an urban problem. And we can see that our model suggests that there wasn't a significant difference between the urban and rural populations in Iowa during the time period that we looked at in regards to the opioid drug mortality. So In the rural Iowa counties, the drug-related deaths in the elderly population is potentially not a prominent issue, but further analysis needs to be performed with the data from the Iowa Department of Public Health to avoid data suppression, as we only used the CDC Wonder data, which is the general population. Next slide. So when we look at our factors, Jacob talked about that some are protective and some are increase the risk of opioid overdose. So we can see that factor 2 had the greatest risk, and which kind of makes sense when you look at what factors were grouped in there, and that's more related to poverty level and things associated with poverty. Next slide. And then we can see that the presence of social capital has a protective effect on opioid overdose deaths, and that kind of means that the more social capital that you have in an area, the lower number of possible overdose deaths that you potentially see. Next slide, please. So looking at some of our limitations, when we look at the data that we used and kind of our overall project, we saw that there was the CDC Wonder data was suppressed. So this prevented us from determining drug and alcohol related deaths in the elderly population in Iowa. This is mainly due to there's a lower number of cases in the over 65 age. So that you look at that is a good thing as far as the number of deaths, but kind of gets away from what we were trying to specifically look at. We would want to use the Iowa Department of Public Health data to find those, to compare those deaths in the elderly population over 65. Next slide, please. We also had issues with our obtaining the Iowa Department of Public Health data. So the biggest issue that came up with that was just the nature of our grant being a micro grant. It would give control of the data to the student versus an institution. And we couldn't find a quick way to resolve that issue so that the institution was in control of the data versus just a single student, and all the problems that arise with that. But that is something that we want to look at in the future to make sure and try to get back to what our original research question was. Next slide. So again, future direction and kind of additional predictor variables that we found in our literature review that we want to kind of explore. Those would be social capital, socio-demographics, which would be the percent population with less than high school education, geography, prescribing practices, and the availability of substance abuse treatment programs in an area. Next slide. So kind of rounding back on our learning objectives and what does each of these mean and what did our data show us? So when we grouped everything into factors, we saw that factor 1, 2, and 4 carried a more significant risk of possible opioid drug overdose in those areas. If there was a higher percentage or number of those factors in an area. And we saw that factor 3 was protective. So the more social capital you have in an area, that lowers the risk of opioid overdose deaths in that region or community. So kind of what does all this data mean and what can others take away from this? I think the biggest thing that we want to show and to help out with these communities is to show certain factors that if you have a higher percentage of these in your area, if you focus on them more, you can potentially lower the number of opioid overdose deaths. While, like what we saw with factor 3 being protective, if you have more of those institutions or establishments in your area, that can help lower the number of overdose deaths in your community. So I think with that, we'll open it up to questions.
All right, thank you. And I've reminded everyone participating to go ahead and post your questions to the Q&A section. I don't have any at the moment to read off, but I guess from my point of view, obviously you have some of these things are protective, but probably building more churches isn't a reasonable intervention for opioids. What can counties do to impact opioid deaths in their area?
This is Jacob Garner. Just looking at the, based on what we found and looking at the non-protective factors such as poverty and people and disability and things like that, there could be measures maybe that could address helping people out of the poverty limit. I'm not sure. I don't know any off the top of my head. I'm unfortunately not a public health official. I'm a medical student, but and I'm not also either a politician, so I don't know how to get that stuff passed. But that could be something as well. There were, besides just churches building or something like that, you could increase maybe funding or support of nonprofit organizations or like membership associations in areas to help alleviate, to give more protection to the area.
Yeah, this is Devin. Kind of following up with Jake. I think like reducing the factors that increase risk is one way to help these communities, but also like falling in with the presence of social capital. I think that also reaches to just different support structures within the community. So having those establishments available, I think would help kind of go along with being a protective predictor for overdose drug-related deaths.
All right, thanks. 3 questions popped up while you guys were talking just now. So the first one was, is Des Moines University urging students more towards rural areas? And if not, I guess, how did you guys come across this project?
Bree, do you want to answer that one?
Sure, I can go ahead. So several of us in the group had an interest in rural practice before this started. Several of us went on a service trip actually a couple months prior to starting the project. So it's something that we're passionate about doing and that we shared as a group.
Okay.
I can add a little on there. The osteopathic medicine type format, or the school, has kind of been in the long run seen as preparing physicians to help in rural settings. Currently, I don't know if that's always the case, but our school does have a rural medicine course, as well as a rural service trip that Bree mentioned that we all went on. So they definitely have incentives, and not incentives, but outlets for us to explore rural medicine and maybe develop ourselves that way.
All right, good answer, thank you. Next comes from someone I know who works in research, who said, great analysis. What software did you use?
So again, this is Jacob. We used SAS and SPSS software packages to do a lot of the work. I'm dabbling in statistics, and Dr. Galetta was really helping a lot on the work here. He might be able to explain more nuances if you would like, but we used SAS to kind of gather the data from the different sources and put it all together. And then we used SPSS for most of the analysis portion of it.
All right. And then the last question I have, unless somebody types another one, have you researched any of the harm reduction coalitions within rural areas in Iowa to assist with data collection? Does that mean no?
I can go ahead and take this if you guys like. This is Nellie Gazarian. We actually have not. This project did get halted a bit because of the COVID-19 shutdown. There are additional parts to what we would like to do, and a huge part of that is making sure that we have community stakeholders, physicians, and mid-level practitioners involved. You know, we'd like to have a sit-down conversation with them and see what they're seeing at the front lines. So huge parts of our project have still not been rolled out. I think that's a wonderful suggestion and definitely something that we can look into as we wait to see what happens with the pandemic and when we can get back to working on this project.
All right. And I know a lot of people have had their lives put on hold because of the pandemic. So that's a very reasonable answer at this time. And personally, my first job out of grad school was running a syringe exchange program in rural California, though rural California is not the same as rural Iowa by any stretch. So keep up the good work, you guys. And with no other questions, again, thanks again to Devin, Jacob, and Brianne for their presentation today. And at this point, I'm just going to go ahead and turn my camera back on so you can see me in my kitchen. So again, please join us for the next 3 days at noon for what would have been breakout and poster sessions at our in-person conference, which would have occurred the first week of April. So yeah, just 3 days left. Tomorrow we'll be leading off with Deb Thompson, a former IPHA board member. And any previous presentations, be sure to check out on our IPHA YouTube channel. We may be social distancing, but we're still in this together, a network of colleagues dedicated to public service in Iowa and public health in Iowa. So thank you all again for joining us, and stay well.